Good afternoon or good evening, and welcome to the Managing Symptoms of Psoriatic Arthritis webinar sponsored by the National Psoriasis Foundation. With that, I'm pleased to turn the call over to your host today, Kathleen Carter from the National Psoriasis Foundation. Kathleen, please go ahead.
Thank you so much. Hello, everyone, and welcome to today's educational webcast, Managing Symptoms of Psoriatic Arthritis. During today's presentation, Dr. Howard Blumstein will discuss ways to manage pain and inflammation, including systemic medications and physical therapy, while offering tips for leading a healthy and active lifestyle. Before I introduce today's speaker, I'd like to take a moment to tell those of you who may be new to the Foundation about who we are, our mission, and what we do. The National Psoriasis Foundation is the world's largest nonprofit patient advocacy organization dedicated to psoriasis and psoriatic arthritis, and we serve as a voice for millions of Americans who are affected by these diseases. Our mission is to find a cure for psoriasis and psoriatic arthritis and to eliminate their devastating effects through research, advocacy, and education. In order to move our mission forward, we engage thousands of volunteers around the country in activities that will lead to a cure. Nationwide, our volunteers are visiting their local elected officials, asking Congress to support legislation to increase access to treatment and funding for psoriasis and psoriatic arthritis research, raising money and awareness through our Walks to Cure Psoriasis and special events, and participating directly in psoriasis research by donating DNA to the Psoriasis Foundation Victor Henschel Biobank. For more information about these opportunities, log on to our website after today's program, www.psoriasis.org. Programs such as today's webcast are made possible through generous donations from people living with psoriasis and psoriatic arthritis. When you visit our website, I encourage you to explore your options for supporting these informative programs. Now I would like to introduce our guest speaker, Dr. Howard Blumstein. Dr. Blumstein is a practicing rheumatologist at Rheumatology Associates of Long Island in Smithtown, New York. He is a clinical associate professor of medicine at Stony Brook University Hospital and participates in the Rheumatology Fellowship Program. He has a wide range of clinical interests and cares for patients with psoriatic arthritis, rheumatoid arthritis, scleroderma, and other diseases. Dr. Blumstein has been recognized by Vitals.com and has received both Compassionate Doctor recognition and a Patient's Choice Award since 2008. Welcome, Dr. Blumstein. We are so pleased to have you here today.
Thank you very much, Kathleen. And I really want to thank the National Psoriasis Foundation for inviting me to do this presentation, and hopefully it'll be helpful and informative to your constituents. So we're going to be talking a bit about ways of managing symptoms of psoriatic arthritis. Before we get to that topic, of course, we're just going to do a little broad overview of psoriatic arthritis in general. So psoriatic arthritis is a type of inflammatory condition. It's a chronic condition, so typically it starts at some point in a person's life, and we have patients that might develop it at a young age, so there are certainly children that can develop psoriatic arthritis. Most people, though, develop it a little bit later in life, so possibly in the 30s, the 40s. All told, it affects up to about 30% of people with psoriasis. And this is a little bit on the high side. There's some estimates that say as few as 5%. But again, still a good portion of people with psoriasis may have some joint involvement from their disorder. And, of course, it's important to recognize it and have appropriate referral and evaluation. We have very good dermatologists where I am, and, if they have an individual that has psoriasis, they will often, ask them about joint complaints, because if their skin manifestations aren't that severe, they, may be on very mild medicines, but at the same time, if they have joint involvement, they could have potentially joint damaging disease that could be stopped, but only if it's recognized. All told, the skin disease usually comes before joint involvement. In some cases, like, for example, in children, you can see skin disease coming after, which becomes a little bit more difficult in terms of deciding what the actual inflammatory arthritis is. When we say inflammation, just generically, so if we divide arthritis into two broad categories, and there are many types of arthritis, but broadly we talk about inflammatory arthritis and degenerative arthritis. when we say inflammation, we mean that there are signs and symptoms of inflammation. So that means that there is swelling, often redness, warmth. Usually a person feels more symptoms in the morning. As the day goes on, they actually improve. In contrast with, let's say, degenerative or osteoarthritis, which affects almost everyone, and typically you'll have more symptoms with use. When you wake up, you might feel fine, and at the end of the day, you may not feel so good if you've been overdoing it. And of course, having one doesn't preclude having the other, so there are people that can have both osteoarthritis as well as an inflammatory arthritis. In terms of symptoms, you can definitely see things like fatigue, so generalized fatigue, and that has to do with not just the obvious. So, when someone has pain, that will fatigue you, but it's actually a disease process. So people with psoriatic arthritis have inflammatory proteins that can cause fatigue. They will have some degree of joint involvement, of course, otherwise they don't have an arthritis. And in psoriatic arthritis, it can affect joints. It can also affect tendons and ligaments. So that's actually one of the hallmarks of the condition. So as a very broad class, we refer to psoriatic arthritis as something known as a seronegative spondyloarthropathy. And there's a few other examples of it, but all of these conditions often will involve some degree of tendon or ligament inflammation. So people might have plantar fasciitis and Achilles tendonitis or tennis elbow and have it for no apparent reason, or have it over and over in recurrent episodes, or have very severe episodes of tendinopathy. Swollen fingers and toes will certainly be a part of it. One of the things that we use in terms of diagnosing psoriatic arthritis would be the having a history of something called a sausage digit, which it's an inflammation of an entire digit. So not just a joint, but rather the full finger or a full toe. That's something that I'll routinely ask my patients about when I'm trying to decide whether they have psoriatic arthritis. Reduced range of motion occurs. That's both from inflammation as well as from joint damage. Morning stiffness I touched on before. So the first question that I ask a patient that I'm evaluating to determine if they have some type of inflammatory arthritis is whether or not they have morning stiffness and how long it lasts. So if someone says that they're stiff for 10 minutes or 15 minutes, that may not sound great, but that's actually not abnormal. If someone is stiff for a half an hour, 45 minutes, an hour, 2 hours, that's not normal. It never is. Nail changes, a lot of patients with psoriatic arthritis, about 80% will have some degree of nail changes, and they can vary from things like nail pitting, which are little pits in the nail, and generally you want to see about 20 or more to say that it's true nail pitting, or just destructive changes in the nail, or psoriatic plaques over the nail bed. Redness and pain in the eye. So going back to the slide before, chronic inflammatory disease of the joint, it's also a systemic disease. So it doesn't just affect joints. It can affect other organs. So it can affect the eye. You can have inflammatory eye disease. You can have involvement of the bowel as well. You can have not necessarily Crohn's disease, but something in that realm, and the two can go hand in hand. And, of course, it involves the skin. In terms of steps to treatment, the first thing to do is to identify it as psoriatic arthritis. If someone has psoriasis and they have joint issues that are unresolved and unrelenting, then it's important to have appropriate evaluation by a rheumatologist. Diagnosing it is very important because we can, with the medicines that we have available, potentially prevent permanent damage to joints. So a rheumatologist is a specialist. So this is a person that's done a residency typically in an internal medicine, or for children it would be a pediatrician. So they've done 3 years of a basic residency, and then they've done either 2 or 3 years of advanced training in a fellowship to be able to diagnose and manage inflammatory arthritis and also know how to manage the medications. As far as resources to find rheumatologists, certainly the National Psoriasis Foundation is an excellent resource, and they have identified rheumatologists that are familiar with psoriatic arthritis. My own professional organization, the American College of Rheumatology, is a great resource. your dermatologist will usually have some good names, and of course your primary care provider would be another important resource in terms of identifying a competent rheumatologist that can help define it, and then if it is psoriatic arthritis, start managing it appropriately. So treatment decisions. How do you know what treatment is right for you? Well, there are a lot of different factors that determine treatment plan. So the degree of psoriatic arthritis, the type of psoriatic arthritis. So there are different types. Generally, we talk about 5 different types. So the first type is a type that looks a lot like rheumatoid arthritis. You get symmetric involvement of small joints of the hands, the wrists, the feet, and the only clue is that the person definitely has psoriasis, and they may not have some of the blood findings that we see in RA. Another type is one that affects 1 or 2 large joints or 1 or 2 joints in general. It's called an oligoarthritis, so not many joints, and it may be asymmetric. It may not be that severe, or it could be very severe. Another type is something called arthritis mutilans. That's a very, very aggressive form. So, in other words, the type of psoriatic arthritis will determine treatment, because if you have extremely severe disease, you need to manage it much more aggressively. On the flip side, if you have a person that comes in that definitely has an inflammatory arthritis, but they have 1 or 2 joints, you may be able to get away with a milder medicine. Or it just may not be worth it to them to get aggressive, especially if their skin isn't that bad. If their skin is, very, very involved and they have bad joint symptoms, then I don't think that there's going to be much of a question that you're going to want to be as aggressive as possible. Localized versus widespread disease, location of joints, and then, the severity of correlated psoriasis. And the two can go hand in hand, or they could be completely opposite. So I have patients that have very minimal psoriasis, but they have very severe joints, and I have others that have just a little bit of joint involvement, and their primary disease is actually their skin disease. As far as treatment options, we talk about 4 major treatment options: nonsteroidal anti-inflammatory medications, disease-modifying anti-rheumatic drugs, or DMARDs, which would include some of the newer agents like the biologics, rehabilitation, which can certainly play a very important role, for example, occupational therapy for working on hand contractures, deformities, assistive devices, physical therapy if you're involving large joints, or let's say an elbow contracture, and surgery in some cases. Generally, surgery is for something that has already been destroyed beyond the point where medicine can help. So what do anti-inflammatories do? So NSAIDs, non-steroidal anti-inflammatories, they cut down on the production of a molecule called prostaglandin, and there are a few different types of prostaglandins, and these are involved in inflammation. So they will help to reduce the swelling in joints, the pain, the degree of morning stiffness, and improve in your overall function. And they're both prescription and over-the-counter anti-inflammatory medications available. If someone has very limited disease, it's not an inappropriate choice. So not everyone has to go on a heavy-duty medication. So if someone has, let's say, 1 or 2 joints, they go on an anti-inflammatory and their morning stiffness is reduced to 15 minutes, and you follow them long-term and you see that there's no progressive joint damage, that's an acceptable, appropriate choice for that individual. Most people, unfortunately, that see me require a heavier duty medication approach. But I do have a few that are just on anti-inflammatories and they do fine. Of course, with anti-inflammatories, like any medication, there are side effects, and we, certainly worry about potential bleeding risk. So, for example, ulcers or GI irritation. We worry about potential for liver or kidney injury, and that's why even if you're taking an over-the-counter medicine, you need to be monitored periodically by a physician doing blood work so that you can make sure that it's not impairing any of your organs. And then there's always the question of cardiac risk. So some of the medications may increase the risk of heart disease. Across the board, all anti-inflammatories currently carry a black box warning. So black box warning means that as a class, they're just putting them all together and they're saying they may increase the risk of heart disease. They aren't going to define it. There was a recent report just out a few weeks ago about naproxen being possibly one of the few anti-inflammatories that may not increase that risk. But again, long-term observational or long-term prospective trials are needed before you can really be definitive about that. Let's move to the next slide. So these are examples of NSAIDs. So Celebrex, Indocin, it's kind of an old drug, meloxicam, and some of the over-the-counter NSAIDs, ibuprofen, Aleve. It's always important to tell your doctor what you're taking, including over-the-counter medications, because you may be taking something that you think is just for pain, an over-the-counter NSAID, and then if your physician is also giving you an anti-inflammatory, the two won't necessarily result in any improved efficacy. In fact, they actually will compete. So if your doctor gives you a prescription for Celebrex and you're also popping Aleve, you might actually get less effect by taking both at the same time, but your risk of side effects will actually increase. Something like acetaminophen or Tylenol, that's not an anti-inflammatory, but it could be helpful if you still have pain despite an NSAID. So again, I've touched on, the most common side effect is GI upset. Ulcers would be a very significant risk. And there are some reports that have shown that indomethacin may actually worsen psoriasis. That's one particular anti-inflammatory. Again, this is an old drug. There aren't too many people that prescribe it except occasionally for gout. And again, there is this black box regarding the potential for cardiovascular or cerebrovascular risk. So DMARDs, so disease-modifying agents, are drugs that they help with symptoms, but they also potentially slow down or stop joint and tissue damage and the progression of the disease. So there are traditional systemic drugs, and then there are newer, more tailored biologic medications. So some of the oldies. So we have Plaquenil. Plaquenil is a very good drug. We don't use it much in psoriatic arthritis. Anecdotally, there are some reports that say that Plaquenil might actually worsen psoriasis. It's never been consistently proven, but again, it's not really used too often for psoriatic arthritis. We use it for very mild rheumatoid arthritis if it's early in the disease and there's not much damage. We use it very widely for lupus. Methotrexate we definitely use for psoriatic arthritis. It's also very widely used for psoriasis, and it has a great skin effect. It does have side effects, and it again has to be managed by a physician that knows how to use it. It can potentially cause liver damage, and it has to be monitored. There are both oral and injectable forms. And in the past, there used to be a routine for doing a liver biopsy if someone was on it for a period of time. Now it's generally not done unless there's an abnormality in liver enzymes. And let's move on to the next slide. So Imuran, this is an old drug used often for rheumatoid arthritis in the past. It's still used sometimes for conditions that rheumatologists treat called vasculitis. We don't really use it that often for psoriatic arthritis unless there are no other options. Arava is almost a relative of methotrexate. It actually has a fairly good effect on psoriatic arthritis, and there have been some decent studies that have shown that it can reduce the progression of the disease, and it can help with the skin as well. Sulfasalazine I reserve for people that have very mild disease but also have contraindications to other medicines. So it doesn't work that well for the skin. So if someone has very mild disease but they can't be on methotrexate, I might give sulfasalazine a try if they're okay with the idea that it may not help their skin, but it would help their joints. The benefit of using something like Arava or methotrexate or a biologic is that I'm going to hit both the skin and the joints at the same time. So obviously you want to take as few medicines as possible. But again, there are exceptions where a person might, not be able to take methotrexate, but they could take sulfasalazine. So biologics, that's a whole new, about a little over 15 years ago, rheumatology entered into a renaissance, and that's one of the reasons why you have rheumatologists that are my age, meaning almost 40 and not 60, because we have, suddenly a huge armamentarium of medications to manage very severe inflammatory disorders. And the first one that was approved was Remicade. After that, Enbrel came out. Shortly thereafter, we saw Humira, and now we have a whole host of medications, and there are more being developed right now. These are medications that block particular pathways. So unlike things like Arava, methotrexate, Plaquenil, sulfasalazine that hit a whole arm of an immune system, this just hits one area. And most of these are approved to treat both psoriasis and psoriatic arthritis. There are a few that have separate indications, and some that will eventually be, able to be used for psoriasis or vice versa for psoriatic arthritis. And the currently available biologics that we can talk about are TNF inhibitors. So they block a substance in our body called tumor necrosis factor alpha. So it's a chemical signal. In this cartoon, I'll go through it very briefly. So TNF plays a whole host of roles, and it plays great roles in the body. Unfortunately, in certain autoimmune or inflammatory disorders, it can play horrible roles. So in the case of psoriasis, it can lead to the proliferation of skin cells and the psoriatic plaque. In the case of psoriatic arthritis, it can lead to activation of macrophages, monocytes, and other cells, and destroy cartilage and joints and bone. So when it's in balance and a person is healthy, it plays a good role. When it's out of order, you can get great damage. So again, these cause cells to release other proteins that continue to add to an inflammatory process. These are the currently approved, FDA-approved drugs for psoriatic arthritis. We have etanercept. That's a typically once a week injection. There are some people that still take it twice a week. We have adalimumab, which is an injectable medicine that's given every other week. Remicade, which is an infusion, it's given every 6 or 8 weeks. And golimumab, which is an injection that's given once a month. A common question that people ask is, which one do you use or which one's the best? The answer right off the bat is none of them. They're all great, and they're all going to work for some people and others they're not. At some point soon, and when I say soon, I would imagine in the next 3 to 5 years, we'll have fairly good testing to actually predict who would respond to which medication. Certainly it won't be as much of a let's pick a medicine and see if it works, and then if it doesn't, we'll switch to another. But right now, it really comes down to, you select a drug based on the patient, you select a drug based on how comfortable they are injecting a medicine, how often they feel comfortable injecting a medicine, what insurance coverage. Unfortunately, that does affect, sometimes which medication. And they all have good track records, and they can all help dramatically. And in some cases, they won't. And just because one works or doesn't work doesn't mean that another one won't work in the future. Steroids. So steroids are generally medications that are used for inflammation, but they're not great for long-term treatment of psoriatic arthritis. One of the problems with using steroids in patients with psoriatic arthritis is that, especially if you go to big doses, you can actually flare up the psoriasis very significantly when you lower the dose. And long-term use of steroids can cause all sorts of serious health risks. So you can develop atherosclerosis, you can develop osteoporosis, you can develop cataracts and glaucoma. So steroids, once in a blue moon, they're okay. My favorite use would be, just injecting a joint, a local one joint, as opposed to going all over the body or giving a systemic steroid to a patient with psoriatic arthritis. These are some of the drugs in the pipeline. There's a whole list of them, but these are the ones that are probably closest. So all of these, except for secukinumab, all of these medications already have FDA approval for something, which is a good thing, which means that, eventually they will get approval for psoriatic arthritis. So Xeljanz is an oral medication. It just was released this past year for the treatment of rheumatoid arthritis, and they're doing the studies right now on psoriatic arthritis. So it's an oral medicine. It is not a biologic, but fortunately for patients with psoriatic arthritis and rheumatoid, it has effectiveness that's very similar to the biologic medications. Cimzia is an injectable TNF inhibitor. It is approved for rheumatoid. It's been also approved for Crohn's disease and ulcerative colitis. It's been out for a number of years. It has a fairly unique molecular structure, and again, from what I understand, they have already submitted their application to the FDA. So sometime in the next year, we should hear back about the approval. This is another antibody secukinumab. Right now, there are no FDA approvals for it, but they're working on it. Ustekinumab or Stelara, some patients with psoriasis may already be on it. That's already FDA approved for psoriasis, but now we'll get an approval for psoriatic arthritis as well. Right now, there aren't too many rheumatologists that prescribe it, only because we usually don't treat just psoriasis by itself. It's usually someone with both, and because it didn't have the psoriatic arthritis approval, it's not as readily available. So other options for pain management. So we've talked about anti-inflammatories. We've talked about disease-modifying agents. Opioids, so narcotics, they sometimes play a role in patients that have severe joint damage. Despite your best efforts, you're still sometimes going to have to just manage pain. And we do use opioids. Obviously, there are a whole host of problems that can arise, and, a patient that goes on an opioid has to be very well aware of the risks, including things like addiction, dependence, withdrawal. So it's not something that you want to rush to, but in some cases you do need to use it to manage pain effectively. Muscle relaxants can be helpful. When you have a painful joint, it can trigger spasms all over the place, and you can certainly get other, comorbidities from the psoriatic arthritis. Topical gels are useful. Sometimes you can get nice, compounded combinations that have some anti-inflammatory, some local anesthetic that can help relieve pain. And then alternative treatments. So acupuncture and massage certainly could have some usefulness. It's not going to hurt, that's for sure. Glucosamine and chondroitin, MSM, these are all supplements that haven't necessarily been proven to work. People with osteoarthritis sometimes can find benefit with glucosamine and chondroitin. There was one large NIH study that showed that it didn't work. There are other smaller studies, one that was recently published in Japan that said that it might help. In general, I'm not going to go be very aggressive recommending it. If a patient wants to try it, I certainly don't see any reason not to try that in addition to whatever approach the physician is using. Rehabilitation, again, I mentioned it at the beginning, is very important. And if a patient, is starting to feel better, it's time to maybe get them into some rehabilitation program so that you can get them back to where their baseline was. So even if I'm treating arthritis effectively, for example, I saw a woman today with rheumatoid. She's doing fantastic. She's on methotrexate. She feels 10 times better than she ever did, but she still has some elbow contractures, so her elbows don't fully straighten out. Now is the time to get her into therapy. She doesn't have a lot of pain. She doesn't have much stiffness. She feels like she's 80% better, and maybe in 3 or 4 months she'll be able to straighten her elbows out completely. But if I just treat her with medicine, it's not going to deal with the full picture. Again, potential components of a physical therapy prescription might be just general aerobic conditioning, progressive aerobic resistance, proper positioning of joints, and adaptive strategies. And then there are plenty of adaptive tools. I know that the Arthritis Foundation has tools that they can, direct patients to. National Psoriasis Foundation, I'm sure, has tools or resources that you can learn about more adaptive tools if you have difficulty using your hands or manipulating small objects. And occupational therapy is usually probably the best resource for finding appropriate adaptive tools for you. And relief for pain and swelling in the feet. I'm a big fan of podiatry and using podiatrists to assist my patients. So if a patient has a lot of involvement of foot, whether it's with plantar fasciitis or just arthritis, I definitely have referred patients for orthotics. Sometimes a local injection can be beneficial, and having a competent podiatrist fit you with appropriate footwear can make the difference between, being very functional and being able to work and, not being able to walk around because of bad-fitting shoes. Surgery is usually a last resort, but in some cases it's appropriate. So if someone has intractable knee pain or intractable hip pain, and we've done everything we can with medicine, and they're requiring more and more pain medicine, it may be time to consider surgery to replace the joint. Arthrodesis or fusion occurs in a patient that has a painful joint that still moves. Sometimes by fusing it, since it won't move anymore, it won't hurt. It's similar to using a brace, except that it's a permanent brace. This is a slide just showing a surgery that occurred on a wrist where there was a lot of damage to the wrist. You basically lost all the normal architecture, and both of the wrists had to be fused. But again, this person may not have any pain anymore because of that. Exercise is very important. In general, all people with inflammatory arthritis should be trying to incorporate some degree of exercise. I would generally recommend starting very small just so that you can actually do it consistently, so maybe 10 minutes a day, with the goal to get to about 30 minutes or so a day of some type of strength training, range of motion, walking, if you can. And, if you're having pain after you exercise, that would definitely be a bad sign. So it's not, having a little bit of strain, a little bit of ache is okay, but not to the point where you're actually reaching for pain pills. Yoga would be very also useful. Tai Chi is excellent for balance, especially if you're an older person. It's been shown to reduce the incidence of falls. And water aerobics or water exercises in general would be a great way of incorporating exercise. And I'm going to, I believe, turn the webcast over to Kathleen now.
Absolutely. Thank you so much, Dr. Blumstein. That was a fantastic presentation. And now we'll dive right into the Q&A. We've been collecting questions for our presenter in advance and also during this presentation. So keep those coming, and we'll get to as many as we can now. Let's start with this question here. So Dr. Blumstein, does psoriatic arthritis hit different areas of the body at different times? Does it show up in one place and then that settles for a while and it flares in another joint?
The answer is yes. So you can certainly see, a person develop symptoms in one particular area, let's say a hand, and, that might last months or even a year and then move to another area. So, the follow-up question, of course, is why, and we don't know that answer yet. The same reason that we don't know why there are different patterns of psoriatic arthritis. Why is it that some people will have involvement of their wrists and another person, and it won't be a person, it'll be a whole group of people will have just a couple of large joints. There is a reason for it. We just don't have that answer yet. But there are people that are working on that question. If you had to pick the areas where you're going to, be more involved, it would more often than not be an area where you already have some type of damage. So if someone had trauma to a particular joint or group of joints, then, when they have an inflammatory arthritis develop, it wouldn't be unusual to see it start or, often frequently attack that area.
Okay, fantastic. Next question here is, how does psoriatic arthritis affect your joints after injury? And does it cause a longer healing time due to an injury?
So I think I touched on that a little bit. The answer is if you have an injured joint, that's a joint that's already susceptible to inflammation and more likely to have more problems in the future. As far as recovery from an injury, if in general, when we recover from injury, there are immune cells that are involved in recovery, and if you think about the immune system in a person with psoriatic arthritis or rheumatoid arthritis, their immune system isn't doing appropriate surveillance. It's not doing all of the appropriate functions. So that's without even incorporating medications into the picture. So you do have a longer recovery from injury with psoriatic arthritis, and it probably, again, has to do with the fact that the immune system isn't, doing its defense host, but rather attacking joints. Same thing with surgery recovery. It might be a little bit longer, and we talk about, some impairment in wound healing after, a surgery in patients with inflammatory arthritis.
Mm-hmm. Okay, great. Our next question is about a particular location where psoriatic arthritis may occur. This participant says, I believe I have psoriatic arthritis in my hips. Is this a common area to hear sufferers complain about?
So the first question I always ask if someone talks about their hips is, what do they mean? So true hip pain is groin pain. It always occurs in the groin. Most people, when they refer to their hips, they're actually talking about their back. So if the questioner is referring to pain in the lower back, sort of around the buttock, that is not an uncommon place to get involvement. So that's something called sacroiliitis. So we have a joint between our sacrum and the iliac bones in the pelvis, and a lot of people will refer to that as hip pain. Isolated, it's not that common, but, having sacroiliitis with other parts of the body involved there is definitely something that we commonly see in psoriatic arthritis. If the question is just about the true hip, which is, again, groin, then, it can happen, but it's not the most common place to get involvement.
Okay, perfect. Next question we'll ask is one about exercise. This participant says, I experience stiffness and pain getting worse an hour or so after exercising. What would this suggest?
That suggests to me that the person is overdoing it. In general, exercise is good for inflammation. And, if you're talking about someone that purely has an inflammatory arthritis, so no other comorbidities, no osteoarthritis, no fibromyalgia, exercise makes it better. And I would say across the board, my patient population, probably 80 or 90%, if they work out or do some, exercise, they feel much better after that than if they just got out of bed. So if they're stiff right afterwards and they're or an hour later and they feel horrible, either they're just, really deconditioned and they're overdoing it, or, again, it might be some other issue. They may be actually causing some type of injury.
Mm-hmm. Okay. And relatedly, we had a question here from someone about repetitive motion. So does repetitive exercise, like typing for hours, for example, help or hurt stiff joints?
I would say in general, any type of excessive repetitive motion is not going to be helpful. Because it leads to repetitive use injuries. So if you have, if you're talking about really sitting there and banging away for hours and hours, that probably wouldn't be the most useful thing. Moving, great. Excessive repetitive motion, not so good.
Mm-hmm. Okay. Here's a question about the connection between psoriasis and psoriatic arthritis. So this participant says, my psoriasis is worsening, yet my joint pain is under control. I am on Humira for 3 years. I'm tempted to stay on Humira, as given the choice, I would rather have unsightly skin but little joint pain. Does this sound typical or reasonable?
So let's start with the second question. Does it sound reasonable? Absolutely. But I'm a rheumatologist, so I think that's a completely appropriate. It is not atypical. So I have patients that their skin disease still doesn't respond, but their joints are perfect, just like the questioner. If it was my first recommendation, if it was my patient, what I would do is I would definitely not be tempted to switch, but I would mention, talking to the dermatologist about any other modalities, maybe light therapy, maybe trying other topicals. Light therapy might actually be a useful thing because, again, not to take another med, but, some other adjuvant therapy that might help with control the skin since the joints are already okay.
Mm-hmm. Okay, absolutely. Let's move to another topic. We saw a whole lot of questions about this, and it almost always comes up during one of our webcasts, and it's about diet. So are there any particular foods that people with psoriasis or psoriatic arthritis should stay away from, that they should eat to improve their symptoms?
Okay. So I'm going to first put a big, broad disclaimer. The big, broad disclaimer is that, unfortunately, to date, everything that we're going to talk about diet is speculative and not based on good long-term research. That being said, if you wanted to take, the best step towards improving your health and helping to control inflammation both in the skin and the joints, I would say take everything that the American diet contains and get rid of it. And the easiest diet to recommend both for heart and inflammation would be something like a Mediterranean diet. So we know that there, is fairly good data that, there is some link between a Mediterranean diet and potential lowering of some heart risk. We know that a diet that's rich in fish oil and omega-3s and omega-6s can help with inflammation. We know that, a diet that's lower in, let's say, red meat may help with inflammation. So that's generally what I recommend. Now, getting to more specific and saying, okay, should I eliminate all meat or should I eliminate all dairy or should I eliminate nightshades? A lot of that people have tried. Anecdotally, some people will say, oh, I'm great. When I have a patient with RA. She went on a vegan diet. She became perfect. She was on heavy-duty meds. Now she's just on Enbrel. She was on methotrexate, and even with the combination therapy, she was never as good as she is as a vegan. But that's an individual response, and I can tell you for sure that other people have tried it without any success. So I would just approach it from a best health point of view. So a Mediterranean diet, a diet that's going to include, a lot of fish, a lot of, using legumes, using nuts, pretty much in all meals, very little red meat, and, not too much fat, like the bad fat, and not too much sweets.
Mm-hmm. Great. Thank you for addressing that.
And keeping your weight down. That's a big one, too. That's as another side. So if you're able to maintain a healthy weight, so looking at your BMI and truly getting to a real, BMI of 24 or below is going to be beneficial, because there's definitely an association between obesity and the severity of psoriatic arthritis. So even if we don't even think about food, but we just think about a person's overall weight, that would make a difference.
Mm-hmm. Absolutely. Well, this next question here is about the differences between psoriatic arthritis and other types of arthritis.
Yep.
So this questioner asks, how can I tell the difference between my psoriatic arthritis and my osteoarthritis,
Yep.
and does it really matter?
So I would say it definitely matters, because if you have active psoriatic arthritis, there are going to be medications that your doctor might switch you to. And let's say all of your joint symptoms are related to osteoarthritis, and they start hitting you with heavier and heavier drugs, like, let's say, saying that your methotrexate isn't working, let's put you on Remicade, and then escalating the dose to a very high dose of Remicade, and then saying, well, maybe that's not enough, and hitting you with another biologic agent. So you can actually get into big trouble if you're giving someone, with primarily osteoarthritis, heavy-duty, immunosuppressive medicines. So it definitely matters. As far as telling the difference, fairly simple things. From a patient point of view, you ask yourself, when am I worse? If you're always worse in the morning and you're always better as the day goes on, and you don't see much in terms of signs of inflammation, so swelling or redness or warmth, then you're probably dealing with more OA. If it's worse in the morning and you're better as the day goes on and you're seeing swelling, then you're probably dealing more with your psoriatic arthritis. To be more specific and more diagnostic, if your doctor can send you for an ultrasound or an MRI, that might be able to differentiate. So particularly ultrasound of a joint can be very helpful. So musculoskeletal ultrasound, it's usually done by a radiologist. Some rheumatologists do it. I haven't learned it yet, but it's something that I will eventually incorporate into my practice, but it takes a few years to get good at it. It can absolutely differentiate, because you'll see on an ultrasound, you could see signs of inflammation and be able to know for sure, is it just OA or the psoriatic arthritis.
Mm-hmm. Fantastic. We've also had a number of questions about the patterns of pain associated with psoriatic arthritis, and maybe we can address a couple at the same time. So this one questioner asks, why is there pain not only at the joints but throughout the body? And another question is, can psoriatic arthritis affect only the muscle tendons and not the joints?
So I'll answer the second one first. It definitely can affect just tendons or ligaments. It doesn't have to affect joints. You have to have some inflammation somewhere, but if you had someone that had a tendinopathy that was inflammatory in nature, and a few of them, and they have psoriasis, and maybe they have some nail changes, that would be sufficient to make a diagnosis of psoriatic arthritis. The second question, it can be painful in other parts of the body. Again, if I was sitting in front of this individual, I would ask them, what do they mean? So if they're talking about tendons or ligaments, so let's say a person has pain in their elbow and in their wrist, but also in the forearm, I could totally accept that that's probably from psoriatic arthritis involving, some tendinitis, as well as the joints. If they're just talking about widespread pain, it could be something else. So you could be dealing with a person that has psoriatic arthritis and they have a pain syndrome like fibromyalgia. So you don't know based on just the question, but it can be from the psoriatic arthritis, or it could be from an associated condition with it.
Mm-hmm. Okay, absolutely. We've also had a lot of questions about disease progression.
Yes.
This one in particular is, will this disease continue to progress even though I am on a biologic in Arava? And others are wondering how fast this disease progresses, and if you are treating, if you can stop long-term effects of psoriatic arthritis. Okay,
so good news, bad news. The good news is that most people that are on a biologic, in particular, won't see much progression. So when we see, long-term radiographic studies, both in rheumatoid arthritis and psoriatic arthritis, there's a small group that will progress. But most of the people, and I'm talking about upwards of 95%, it'll stop. If you're on a traditional disease-modifying agent, so something like methotrexate, that's not true. So there are people that will progress, and a good number will. But a biologic often will protect the joints in general. The speed at which it can, it just varies. It's so different from person to person. So some people can have very rapidly progressive, and others could have the disease for years and not even know it, and nothing could have happened. But generally, if you're on a biologic and your primary concern is joint damage, it should give you some sense of relief that the likelihood is that it's not going to. But that's, there are some that it will progress. On the flip side, it's probably slowing it down somewhat. So even if you, let's say, are on one of those few that is going to progress, the progression may still be slowed down dramatically. So it'll buy you more time for more things to be developed, and maybe the next thing will be more effective. So.
Mm-hmm. Okay. Here's a question about treatment decisions. Is there something that you look for in particular to determine whether it's appropriate to move from a nonsteroidal anti-inflammatory drug to a DMARD?
Yes. Great question. It's going to be two things or three things. It's going to be, one, how many joints are involved, and is there damage already? So I'll assess damage based on X-rays and MRIs or ultrasound. So if there's already significant damage, then you're already stratifying that person as a high risk for progression. If there's no damage, then you've already stratified them as someone that you don't have to get as aggressive with. If there are one or two joints, most rheumatologists aren't going to jump on a DMARD unless the patient has already failed multiple NSAIDs. So if they've already tried 5 or 6 NSAIDs and they're still suffering and they can't function, then I think it's appropriate at that point to easily move to a DMARD. If someone comes in with 5 or 6 joints, I would say from the get-go, almost all of us will recommend a DMARD, and almost all patients would probably go along with it because that's, at that point, 5 or 6 joints, you're probably getting towards becoming disabled. And if you don't stop it, you will end up disabled. So it's going to be based on the severity of the disease. And then finally, how willing are they and how many comorbidities? If they have comorbidities, that may determine also. Like, let's say a person has, just hypothetically, HIV, hepatitis, B and C, And I know that this sounds like an extreme example, but here's a person that there's not much I can do, because I can't give them, if they have hepatitis B, I can't give them a TNF inhibitor. If they have hepatitis B and C, I can't give them methotrexate either. There are very few options. That person might be someone that I could give safely with very close monitoring sulfasalazine, but so it depends on other characteristics as well.
Mm-hmm. Okay, great. Let's address a couple of questions about physical therapy. Here's one about arthritis of the finger. So do splints help prevent problems with the finger joints?
So splints can be helpful in correcting deformities. If someone is already starting to exhibit some deformities, an occupational therapist could fit them with appropriate splints that might prevent it from getting worse, especially if they're being treated at the same time.
Mm-hmm. Okay, great. And another question about physical therapy. Does physical therapy help someone to walk better? I am almost waddling now because of the pain I'm in.
It might. It may not, though. If you're waddling because you have severe involvement of the hips and you're already on maximal therapy and there's already damage, that unfortunately might be one of those cases that, the only treatment is surgery, i.e. replacements. But it depends on the circumstance.
Mm-hmm. Okay. And you had mentioned earlier in the webcast about GI issues that might be associated with psoriasis or psoriatic arthritis. This questioner would like to know, do you see patients that come in with psoriasis and psoriatic arthritis and GI issues, and can you give examples of some of the symptoms?
So I do. I've had patients that have had colitis or microscopic colitis associated with psoriatic arthritis. So anybody that I'm seeing for psoriatic arthritis, I'll usually screen in terms of, do you have diarrhea? If you're having diarrhea, how many times a day? Are you being woken up by, diarrhea? Do you have blood in the stool? So any of the alarm symptoms for an inflammatory bowel issue. If it's functional things, so functional would be like irritable bowel syndrome, that's usually a separate issue. So someone that's not getting frequent diarrhea, they're having mostly constipation, that may be more of an IBS type of issue. And ultimately, if there's a lot of GI issues, then they definitely need a colonoscopy to evaluate, to diagnose appropriately.
Mm-hmm. Okay. And here's a question, another one about the relationship between psoriasis and psoriatic arthritis. Mm-hmm. This person says, I have a collection of psoriasis sores in the lower back portion of my back, and that is where the pain generally is. Can it be due to the sores that my back hurts so much?
It might, but it might not. Sorry to hedge, but it depends on, so if you have very severe psoriasis with cracked skin, it could certainly be painful. The pain associated with psoriatic arthritis in the back should be deeper, and it should be, more of an ache as opposed to just a sharp skin pain. So I think the person should be able to differentiate between the two things. Imaging studies certainly would help that. If they did an image of the spine and there's no inflammation there, then that should tell you for sure. But I'm sure a physician could, just based on movement, if does it hurt when you're not moving? If it's psoriatic arthritis, it might hurt even if you're not moving. If it's, just because the skin is irritated and you're moving cracked skin, that might be more painful when you're moving around your back.
Mm-hmm, absolutely. We've also seen quite a few questions about the diagnosis process for psoriatic arthritis. So if you could just speak to that a little bit more. We have some folks here. One question is there a way to determine joint damage when there is not tremendous pain? Another person says, if you have psoriasis, have developed nail psoriasis, will you definitely get psoriatic arthritis? Does it always lead to arthritis?
Fortunately, it does not always lead to arthritis. So again, the minority of people with psoriasis will have psoriatic arthritis. Most people with psoriasis, even if you have nails that are involved, won't get psoriatic arthritis. As far as the diagnosis, so the diagnosis is a clinical diagnosis. That means that there is no specific test. In 2010, there was an organization that developed a group of criteria called the CASPAR criteria, CASPAR, and it stands for Classification of Psoriatic Arthritis. And it basically put together a group of symptoms and findings that would be highly, highly likely to be associated with psoriatic arthritis. And they were things like, one, you had to have some type of inflammatory arthritis. So it either had to be some type of spine involvement, some joint involvement, some tendon involvement. So someone that has, that 45 minutes or an hour of morning stiffness in one area. The second thing was you had to have some history of psoriasis, either a personal history, a very close family history, or a prior history. The next thing was nail changes. The next thing was sausage digits. So if someone came in with a sausage digit and you saw it and, they had psoriasis, the likelihood was it was up there at about 95%. So, again, there's no specific test. There are some other findings that we sometimes look for, but ultimately it's a collection of symptoms in the right patient that would determine it. As far as determining joint damage, imaging is the only way. So you could have, unfortunately, there are people that have very little pain or very little symptom and they've already had joint damage. We usually will do a baseline X-ray. MRI or ultrasound is a little bit more sensitive. I personally do more ultrasounds just because it's easier to do. You can, survey a lot of different joints. So I'll send a patient to a musculoskeletal radiologist, and they could do, both hands, both feet, and they'll be able to pick up damage much sooner than an X-ray would.
Fantastic. We're running out of time here, but I think we have time for at least one more question. This one's about hot and cold therapy. So is heat or cold recommended for pain relief? I find heat much better, but some say that increases the inflammatory and I should use cold. I find cold to make me ache more. Can you advise?
I would go with what you're using. I mean, if it's comfortable, I don't see any reason to not recommend the heat. It's not going to make the inflammation worse. If someone has acute inflammation, like, they just took a hammer and slammed their wrist, then usually you want to ice it, and that, that's to reduce the inflammation. But if it's already comfortable and, this has been going on, your body, you have to trust your body. And I don't think you're certainly not going to do any damage by using the heat.
Absolutely. All right. Well, I think that'll just about wrap us up here. Everyone, thank you so much for all of your questions. I apologize if we weren't able to get to all of them. That health educators at National Psoriasis Foundation always welcome your questions. You can reach us at education@psoriasis.org. And that about wraps up our presentation for today. Before we end for the evening, I just wanted to mention we'll be archiving this presentation, and you'll be able to access it on our website at psoriasis.org/webcast, as well as all of our past presentations. Thank you so much to all of you for joining us tonight, and to Dr. Blumstein, thank you so very much for such an informative presentation.
Thank you.
Thank you. Good night, everyone.